Well, good afternoon, now already afternoon, and thanks for coming to Grand Rounds. I'm sure it's the topic, not the food, that brought you here, but regardless of the motivation, I'm happy to have some folks to talk to and see some of my students in the audience as well. I would be inclined to think this report was just another nice IOM report, except for the timing. And how many of you participated in the university's retreat on health policy, health reform? And I see a handful of us in here that were able to go there. I went for part of it. But I'll tell you, it was an extraordinary event. Just a few weeks ago, they had the senior management and leadership of the university health systems, medical school, but also the hospital, meet together for 2 days to kind of consider together what does health reform mean for academic health centers and what is our future and how are we going to adapt. I was impressed because over the years I've seen these well-intentioned retreats where they essentially talk about how special we are, how we deserve more NIH funding, we ought to get enhanced payment under Medicaid because we serve an important role in society and blah, blah, blah. Well, there was none of that anymore. I mean, there was no kind of a self-satisfied, as some academics can do. I don't mean to be critical, but they can swagger a bit, be pretty cocky and proud of their special role. They're smarter than other people and they're doing important work. None of that is not true. It's all true that they're smarter and doing important work, but the fact is there's not going to be the resources to continue to fund academic health centers from the revenues, or from the customary streams, whether it be NIH or enhanced payment under Medicaid, or whether it be special categorical grants. So there was a very sober realization that we're in a new time. I would say that it reminded me a little bit of the movie Alfred Hitchcock. You're all too young to remember this, but anybody see High Anxiety? Oh my gosh, there are a few hands. Rented on Netflix. If you want to see a really funny Hitchcock movie about high anxiety, where people are really, really wired and worried about something, well, that's kind of the sense you get from that. So the timeliness of this IOM report is that it comes at a time or a context where I think that it's going to be better received than previous reports. I've got to tell you there's nothing revolutionary in what I'm going to present. These things have been talked about and considered in previous efforts. The one that comes to mind is in the mid-1990s when the AMA and the American Public Health Association came together. I think it was called Bridging the Gap, not the quality report on Bridging the Chasm, but Bridging the Gap on public health and clinical medicine. But the difference is that kind of fell on kind of harsh ground. I think this is going to fall on fertile ground, and I think it'll bear fruit just because of the provider times. Let me just give you a little bit of background of an IOM report. They do these things in a way that is really impressive, and that they convene people who have a wide range of expertise and experience, and they meet periodically in nice settings where you really can deliberate in a way and have really good staff support. I'll just run through the members to give you an idea of who they are. Paul Wallace is a physician who was with Kaiser Permanente for a number of years, has now gone with the Lewin Group. He knows not only clinical medicine, but he knows health services research in great detail. Ann Berry was head of the Department of Human Services in Minnesota for a number of years. She's a lawyer, brings together both government, state experience, and legal expertise. Joe Ivy Buford is a primary care pediatrician who's been on the forefront of health policy for decades now. She was trained in Montefiore in New York as a real social activist for health care, but was also the top doctor under President Clinton. She was the Assistant Secretary for Health. Absolutely as smart as can be and very committed to social justice and government role in addressing all of these things. Sean Granis is a family physician who was a computer expert. He's a whiz in HIT, Health Information Technology, which is an important part of reform. Larry Green is a longtime leader in family medicine. He's a good friend, I know, of Mike McGill. He's been a person who kind of promoted the idea of using our practices as research laboratories, kind of a community practice based. What do they call that? Primary Care Research Network. Right. He really lent a a lot of valuable information to our report, and I'll maybe mention that a little bit later. Kevin Grumbach is another leader in family medicine. He's head of the family medicine program at the University of California at San Francisco, and I'm happy to tell you that I preceded him. I was the first chief of family medicine at UCSF in San Francisco, but he was one of our students who rose through the ranks and took over the department and is doing way better than I would have because of his skill at research, and he's a real family doctor as well. Fernando Guerrera is a local health officer, was its local health officer in San Antonio, represented a large, complicated Hispanic population. I remember San Antonio because a few years ago it stood out as being the fattest city in the nation. I don't know if that's still true, but we have an obesity problem in Utah, but you compare it with the South and the North and some of the Midwestern states. But anyhow, he led a lot. Jim Hotz, kind of hard to say his name. He's a primary care internist in Georgia with the Federally Qualified Health Center. Great hands-on experience, and was so compelling that the IOM committee actually went to his community health center in Georgia, Macon, I believe, to do a study of how they integrate public health and primary care. Alvin Jackson was a state health officer in Ohio when I was for Utah, so we were colleagues in the Association of State and Territory Health Officers. And I find it interesting how many family physicians are state health officials. So this is, I guess you might say, I am an embodiment of integration of primary care and public health, and there are a lot of people like me, family doctors who kind of gravitate to public health, and public health people that I think are interested in primary care. But Alvin was certainly a good example for that. Bruce Landon is a rising star. I'll just mention his name because you'll see it again and again. He's one of these early 40-somethings internists at Peter Bent Brigham in Boston who's very, very keen on primary care, but also a researcher. And I just was so impressed with him. He's going, any of you of my age, I mean, no one is here of my age, my generation, is David Blumenthal. He's a primary care internist from Harvard who headed up the Office of Technology, or the Office of the National Coordinator. This is where Bruce Landon will become. He'll be the leader of primary care medicine at Harvard. Danielle Laraquette's a pediatrician from Mount Sinai in New York, and I liked her so much because she would be talking about these social concerns or access to care problems. Well, she was doing these things in the upper part of New York City, or that Harlem area. She talked with a first-hand experience. It wasn't out of a textbook. Lloyd Michener, it's another good friend of Dr. McGill's. He's the head of family medicine at Duke University in North Carolina, and they've done some very commendable things, which we highlighted in this report. Bob Phillips is a family doctor with the Academy of Family Physicians, and he's also a well-respected researcher. He looks so dignified. He actually is a throwback. He dresses and looks like he's something from the past. He's just so conservative and so well-spoken and smart as a whip. I'm promoting him to be the next administrator of HRSA, just to let you know, Mike. I think he'd be a terrific successor to Mary Wakefield. And then there's me, this family doctor from Utah. Mary Wellick is a local health officer from Minnesota and was very vigorous in promoting local health departments' role in this, not just state health departments. And Winston Wong is a fellow that used to work for me when I was head of HRSA many years ago, physician that is now with Kaiser Permanente in Southern California, primary care internist. So I ran through those to let you know that they're accomplished people with diverse backgrounds, and also to impress you that I know who all of them are. I mean, weren't you impressed? I could just tick those off without looking at notes. Good people. Okay, how the committee works. We were asked to find the best examples of primary care and public health integration and the factors that promote and sustain these efforts. Examine ways in which HRSA and the CDC can use provisions in the Affordable Care Act to promote the integration of primary care and public health. Discuss how HRSA-supported primary care systems and state and local health departments can effectively integrate and coordinate on specific topics. How they work is, it was about a not quite a 2-year process, 21 months. We had 5 meetings of the full committee. Some of them are open to the public where they can come participate. 3 of them were subcommittee meetings on specific topics. They did an extensive literature review. And I'm going to pause right here and just tell you this. I mean, you're welcome. There's a hard copy of the report. You can get it online. It's available at the Institute of Medicine site. But one of the most educational things, if you're fortunate enough to be a committee member, you get this incredible education in the process of sitting on the committee. And I have here a handful, just a handful of the many, many, many articles that were shared with us, and I'll just have them here for your review if you'd like. But one that just really, I found this and gave this to the committee, which they shared. It's called Marriage Counseling for Medicine and Public Health by Ronald Davis, which is an outstanding article written in the mid-90s by a man who died way too young. He was a public health doctor, worked for the AMA. But anyway, he talked about some issues that are as relevant today as they were when he wrote the article, and about how we have to get over feeling sorry that we're not working better together and do it. There's another wonderful article just written by the head of the Institute of Medicine, Public Health and Medicine, Where the Twain Shall Meet. An article we commissioned at this report by Sarah Rosenbaum, a legal expert at George Washington University, called Reinvigorating the Primary Care Public Health Relationship, Opportunities under the ACA. There's one by a Dr. Michael McGill called Medicine and Public Health, Whose Agenda? And I was glad he shared this with me, because it's something that he wrote in 1999 that's right on point to the purpose of our study. And the last thing the last reference I'll mention before I get into the body of the report is because, and I'm going to say this, read it, because I think it states even better in some respects than our report why we did this. Why are we focusing on this now? What's the issue here? And I must say that I have to commend the agencies, HRSA and CDC. They funded this. It didn't come out of the private sector. It was government in the spirit of good government, saying, how can we work better together? How can we use our resources better, not just to keep programs going, but to actually improve the health of the people that we're supposed to serve. So has anyone heard of a Larry Gosselin? Lawrence Gostin, I mean, Georgetown University. He and his colleagues wrote an article, Restoring Health to Health Reform, Integrating Medicine and Public Health to Advance the Population's Well-Being. And it's such a well-written introduction. Please bear with me, and I'm going to read this. The Patient Protection and Affordable Care Act is a major achievement in improving access to health care services. However, evidence indicates that the nation could achieve greater improvements in health outcomes at a lower cost by shifting its focus to public health. By focusing nearly exclusively on health care, policymakers have chronically starved public health and adequate and stable funding and political support. The lack of support for public health is exacerbated by the fact that health care and public health are generally conceptualized, organized, and funded as two separate systems. In order to maximize gains in health status and to spend scarce health resources more effectively, health care and public health should be treated as two interactive parts of a single unified health system. So that simply states in a well-said manner why we're doing this report, or why we've focused on this. Okay, I've already done that. What do we mean by integration? We adopted a broad definition, the linkage of programs and activities to promote overall efficiency and effectiveness to achieve gains in population health. Due to variability in local strengths, needs, and resources, the committee did not want to be overly prescriptive. In other words, we acknowledge that how to do this in St. George would be way different than it might be in a rural community in the east or in a big urban center. So we wanted to leave it variable. I think this is a very nice graphic on what we mean by integration. Sometimes we work in absolute isolation. Sometimes we're aware of each other. Sometimes there's cooperation. Collaboration's even better. Partnership, eventually leading to a merger. For example, I'll give you something that we typically say mental health and clinical health are separate. You have to go to a different facility. Well, I still volunteer as a family doc at our state health department clinic every week. And we have, through some funding from Intermountain Healthcare and through NAMI, the National Association of, what's NAMI? National Association of National Alliance for Mentally Ill. I was trying to figure out where the I came in. We have behavioral health workers right on site in our clinic. We've gone beyond cooperation. We're actually merged. And I can't tell you how helpful that is when you're doing primary medical care if you have behavioral experts right on site that will help you with prescribing of these psychotropic drugs, which can have side effects and be confusing. And also if you have issues that you're not comfortable treating. And then conversely, when they're seeing a mental health patient on site at the same clinic, and if they're concerned about their blood pressure or diabetes, they can have us see the primary care doctor. So that's what we're hoping to do with public health to a degree. Although you might not need practitioners on site, you need to be aware of the principles and practice of public health in a primary care setting. Let's see, I'm going to make sure I'm going in the right direction. Okay, why integrate? I think we understand that it's all about efficiency and economy, capacity issues, and everybody benefits. Why now? The dramatic rise in healthcare costs have led many stakeholders to embrace innovative ideas, just like with our retreat at the Health Sciences Center. Like I told you, we didn't see much pushback. We just saw some kind of realism and acceptance that we're going to have less resources, so how do we do our jobs better? Health research continues to clarify the importance of social and environmental determinants of health and their impact on primary prevention. Anybody who've taken the social context of medicine class should be well aware of this. An unprecedented wealth of health data is providing new opportunities to understand and address community health concerns. And the ACA presents an overarching opportunity to change the way health is approached in the United States. Without digressing too much, because I do want to get through all the slides. By the way, these slides are the official report presentation provided by the IOM. I didn't develop these based on the report, so you have the benefit of having had this presentation in person that was given at the National Press Club just a couple of weeks ago. But before we get into these examples, I'd just like this smart class, the smart group, raise your hand and tell me some examples of why you think the ACA what are the opportunities the ACA gives to do this? Anybody can think of anything in the health reforms that were recently passed? What does it do to make it more likely that we can integrate public health and primary care? Jim?
I'm not sure that the dynamic, but I think bringing everyone theoretically into the pool has got to help with funding and any number of issues related to this.
You mean to have more people insured?
Yeah, including young folks.
Okay. Jenny?
I just wrote a grant, and that was money that put aside that was already being spent for HRSA to encourage public health and primary care programs put together. It was a joint degree. And so there was money already being spent to stimulate that kind of thing. Hopefully we'll get it.
Megan?
They've got a bunch of prevention measures in it, so and those are going to affect for sure.
They really are. There's some good articles written about all the prevention aspects of the ACA, and we won't go into them now, but I'll just say the climate is different. I think just as Jenny said, you're going to see grants with a funding preference for integrating public health and primary care. So if you or any of you dependent on grant money, to the extent you can talk about this and include it in your process will be probably favorable for your getting funded. So to help people understand this, we did cite some examples: Durham, North Carolina, San Francisco, New York. Again, they're as different as can be because of the different communities. In Durham, North Carolina, they had it was under the leadership of Lloyd Michener and the family medicine people, where they have done this and actually merged financing, which made a big difference. If you merge public and private funds in this capitated arrangement, you can focus on public health. San Francisco is interesting in that it was really at the leadership of their mayor. They had a mayor who wanted health coverage for all, and so on paper they do have open access to health care in the city of San Francisco. I can only tell you from what I understand about this partnership, it was to help shore up that notion of universal coverage in the city of San Francisco. It sounds great on paper. In reality, it's lacking a bit, but nonetheless it's their intention to have everyone live in their city have insurance. And as far as I know, it's the only municipality that's adopted a universal coverage concept. Does anyone know of a state that has?
Massachusetts?
Actually, yeah, I'm just trying. They have the mandate, you're right. But the other one that has universal access is Vermont, and that's still being rolled out and implemented. So there's this notion where we're going to try and get there. The Republicans should like it because it's kind of like using states as laboratories for health reform. But anyhow, this is one where a municipality did. In New York, their key of their effort on integrating these things was HIT. And I don't want to in any way diminish the importance of that, because some of the ways where we integrate public health and primary care are for people in practice, family docs, internists, whatever, doing reporting of reportable diseases. And instead of making that a card you have to fill out, and which is timely and difficult, I did this as a young family doctor. Did you fill out the measles cards? And if you had an infectious disease, I'd mail it in, or a hepatitis card. And I was a pretty good citizen. I probably did it a third of the time. but anyhow, that's pretty slow and not very accurate. Now, if you had a EMR and you have a reminder, or you had a menu of reportable diseases that would pop up, it would be so darn easy to just click the patient you saw and send that to the health department. And conversely, if you can get reminders of immunizations on your electronic medical record, can you imagine it'd be so much easier to keep everybody current? And I have a list that comes up of preventive services on my EMR at the health department that tells me what a 55-year-old woman needs in the way of mammography or colonoscopy or flu shot, or when she'll need a herpes shot, the shingle shot. Anyhow, those things are, the HIT is an enormous tool, and that's what New York has demonstrated some benefit from. So let me run through the rest of these slides, and then we can have some discussion. This is kind of, they're kind of dense, but there's some information here I hope you'll find useful. The principles for successful integration it has to be a shared goal of population health, and that has to be in a community. It has to have aligned leadership, bridges discipline programs, jurisdictions. Whenever these areas where they've worked, they've gotten everybody together. It has to be sustainable, and then there has to be some sharing of data analysis. The only counterpart I can think of this here, and I'd welcome any suggestions to the contrary, but the only place where I think in our community they get everyone together to deal with health is Health Insights. Is there any other forum for getting us all together? I think, how many of you are aware of Health Insights? Okay, you ought to know about it if you don't. That's our quality improvement organization. Every community has them, every state, and they're sometimes multi-state, funded by CMS or the Centers for Medicare and Medicaid. But ours is not only a quality improvement organization in the traditional sense of the word, where they review charts and see if we're meeting certain HEDIS standards. It also is the site where we're doing the Beacon community and HIT. So they get hospitals and doctors and insurers together to deal with common concerns. And I was kind of intrigued when I saw these principles to think in our community. I'd like to make this presentation to them to see if it would gain any interest in their showing some leadership there. Potentials for interagency collaboration. Now this gets kind of wonky, and you'll have to forgive me for going through the government part of this, but remember who funded it. It was the CDC and HRSA. So much of what you're going to read about are things that were related to how do they work differently or better together. And some of you probably know I used to be administrator of HRSA, Health Resource and Services Administration, a long time ago. And I can see that we did things then that I wish they still did, because I think we worked better together then than maybe we are now. But anyhow, there are opportunities for them to collaborate. They should examine, whoops, let me see, go back here. What they're saying here is they should, sorry, this is tricky, got a trigger happy. Okay, examine how they can work together, for example, on maternal and child health. Oh, I know, I'm touching the screen, that's why. Sorry. Maternal and child health, cardiovascular prevention, colorectal cancer screening. These are things which, if you had to assign an agency to, MCH is in HRSA, a big block grant. Cardiovascular disease prevention is at the CDC. Colorectal cancer screening is at the CDC, but they're all about improving the health of the population. So they got to get over their separation. For example, they got some ways where they could collaborate better together. where there's interest in working together, some ways you could do it include use of community health workers, sharing data across the agencies, which they don't now do, involve third-party payers to bring the two agencies together, and in the case of this, it means mostly Medicaid. Now, here are some more answers to questions that I posed earlier. Why is the environment different? These are some things, components of the ACA. Everybody knows that health reform is about expanding health insurance coverage, raising the eligibility for Medicaid, doing insurance regulations. The primary goal of the ACA, and if you're taking my final in health policy next week, you should know this, is to expand health insurance coverage. That really was the goal. And why did it fall short according to the Democrats? Why don't a lot of Democrats love the ACA? It's not a single-payer system. They don't achieve universal coverage. It's building on our traditional insurance programs, albeit with a heavy emphasis on Medicaid, but most of that expanded coverage would be on insurance reforms in the private sector, you know, so they could do away with pre-existing conditions and making sure kids are covered up to 26 and making it hard for people to be denied coverage. Well, that's pre-existing conditions. But anyhow, we would all benefit, but they say in the best scenario it only get up to about 96%, and that's hardly universal coverage. That's still millions left without insurance in our country. And of course we know why the Republicans don't like it, and that's because it's too much government and it's imposing a mandate on everyone to have insurance. But these are some good things that are in the ACA that have nothing to do with insurance per se. There are community transformation grants that CDC has funded, and they're all great. They're to go to local health departments to address obesity or some problems in their communities. Community health needs assessments. I'm not talking to my class. We had a woman from Intermountain Healthcare come talk about the amount of money and effort they invest in assessing the needs of health in the state of Utah. Really impressive. They can give you geographic indicators of where the gaps in care are and what the needs are, and of course they have a vested interest being part of a big hospital system, but it's public. It's made available to the public. But anyhow, there's money to do these community needs assessment in the ACA. Medicaid has to expand their preventive health services. Community health centers are expanded and beefed up. National Prevention Health Promotion Public Health Council was established, run by the Surgeon General. CMS has an innovation center which has big money. CMMI, they call it, has $10 billion authorized to do some of these demonstrations in how do you do community or population health better. What are some innovations to do that? And we've applied for some of those funding. Have we heard yet?
Did not heard. They were supposed to be announced several weeks ago, but delayed
Indefinitely. Oh, but, well.
They didn't say when it was going to be. They said some weeks.
Okay, well, we've applied. There have been 4 grants come in from the university, some from Intermountain Healthcare. We'll see. So on paper, this is a new opportunity. We'll see what happens. Accountable care organizations, that's the one I'm kind of surprised you didn't all respond to. If you're talking about integrating public health and primary care, there's probably no better mechanism to do that than under what they now call an accountable care organization, which is how they're going to pay people. They're going to try and do capitated funding for populations. And so if you were, say, setting up a healthcare system where you're counting on getting so much money from the federal government to take care of a set population, wouldn't you want to do your level best to have adequate screening, their immunizations up to date, obesity counseling, smoking cessation, all of the traditional health promotion, healthy behavior, and preventive services that we know work. And so that's going to be a real financial incentive based on the payment model that they're going to try and implement. Patient-centered medical homes, we know about the success of them. In fact, I don't know that time will allow, but when I got to address the IOM committee, each of us on the committee had to come present the meeting we had in California, at Irvine, California, on what are you doing to do this? And I was quite happy that I had some things to talk about. I first talked about care by design. I got Michael's slides and showed them what we're doing there. I then talked about Chuck Norland's wonderful grant to provide medical home for children with disabilities, and they're doing terrific stuff, and it's a collaboration with the state of Idaho and Utah. I then talked about kind of bragged about our accomplishments with health information technology and how much more mature we are than most states in this with setting up a clinical health information exchange. So we have in theory, we have the capacity to do a lot of this, and I could had some good bragging rights, if you will, about what we're doing here in the state of Utah. National Health Service Corps, you know the National Health Service Corps is being quadrupled by 2020 if the ACA is funded to that degree. That's significant. Who knows what the National Health Service Corps is? Oh my gosh, this sophisticated group and you're not that aware? Okay, I'm going to give you a little lecture on the National Health Service Corps because I think it's really important in our efforts to serve the underserved. The Corps is not a uniformed corps. It has a nice name, but it's not anything to do with the military. You don't even have to sign up to be in the commissioned officer in the public health service. You can just do it. But the Corps is where the federal government will give you either loan forgiveness, significant loan forgiveness, like $100,000 a year, or a scholarship. They don't have so many scholarships anymore, but in return for that, you've got to be willing to serve in a federally designated underserved area. And the Commission Corps has been a success story, although it has its detractors, because people say, well, half of the people don't stay in an underserved area. They just put in their time and leave and go work in a city where they can make a lot more money. Well, I tend to be a half glass full kind of person. I say, do you mean half of them stay? Oh my gosh, let's count our blessings. If half of the people, what they've documented is half of the people don't necessarily stay in the community where they were assigned, but they go to a likewise unserved community. They like that kind of, whether it be a rural lifestyle or an inner city area, whatever kind of disadvantaged population, they like that kind of care. So it's been very successful, and Republicans and Democrats alike, under President Bush, he beefed it up along with community health centers, and now the Democrats have even beefed it up even more. But under the ACA, they use that as one of the ways where we'll get at the underserved and fill in these gaps or health disparities. So the National Health Service Corps is something to think about, and it's not just for physicians. You can be dentists, I think some social workers. There's a broader definition of health provider. So if anyone's interested in loan forgiveness in return for service, you might want to check that out. And there's a brand new thing that's been established called the Teaching Health Center, THC. And that's based on the hope that if you train residents in these underserved areas where they're working in primary care settings, they're more likely to stay. Previously, all the money for GME and graduate medical education had to go to a hospital to run a residency. This is kind of a new vision that you don't have to be do your postgraduate medical training in a hospital. You could do it in a community health center. So it's small, and it's a good, well-intentioned effort, and we'll see if they take hold. So, Michael, before you leave, you'll be tested on these later, all these various things. Okay, no, just the good news is we should be positive about some of the good things in the ACA that would promote integration of public health and primary care. So now you've got to bear with me to run through the findings and conclusions, and some of this is kind of wonky, like I say, kind of government-centric or what have you, but I think there's some meat in here. Okay, the principles for integration represent an aspirational yet actionable framework. Know what I mean by wonky? They start talking fancy here. One of these is so bad I could hardly read it. But anyway, they're raising the bar. They're setting the objectives. The committee finds that the current state, the infrastructure for both primary care and public health is inadequate to achieve the nation's population needs. I couldn't agree more with that. It, of course, is. Current patterns of health policy, focus and investment lack the alignment necessary to develop an integrated and enduring national infrastructure that can broadly leverage the assets and potential of primary care. So in other words, we have a public health system, and also if any student of mine needs to know, when we talk about the system, you should really think of that in three phases. It's federal, with all these agencies, and there's states, every state has a health department, and locals. How many local health departments do we have? 12. We have 12, and they do a lot of important work in Utah, but you know what? They're as different can be, and they don't even like each other, and they really hate the state health department. So we have a lot of work to do to integrate. I'm being a little facetious here, but they would probably agree with me that we have our challenges. So anyhow, we have a public health system, then we have the private system, and the private system is pretty varied too, because we have some people working for Intermountain Healthcare, they're salaried. Some people working in the university, they're salaried. Then we have a lot of entrepreneurial doctors still in private practice doing their own thing. So to observe that they're not, they're diverse and integrated is an understatement. Academic health centers are often well positioned to facilitate the integration of primary care and public health. How successfully has that happened here? Who works in one of our university clinics? Anybody here? Joe, don't you? How well have they integrated public health principles and practice in their clinical setting?
I think it's variable for some.
Okay, well, I do think we're better positioned than other entities to do this integration. The committee believes that a starting point for catalyzing and promoting greater integration of public health is leveraging existing funds and policy initiatives. And here, let me see here, the recommendations. I'm going to try and summarize these for you because they get a little dense, but let's just run through them. Number one, link staff funds data in the regional, state, and local levels, HRSA and CDC should. And again, they're talking about pooling funds. I can just tell you to my satisfaction, I talked to the Deputy Director of the CDC a few weeks ago, Judy Monroe. They're already going to do some joint funding projects. This is unheard of. For CDC and HRSA is going to announce a funding opportunity, put a request for proposal, understanding they have a common goal but different programs. So they've already identified opportunities to merge funding streams, create opportunities for staff to build relationships, to work with each other. You have the staff, CDC's in Atlanta. They're pretty remote from Rockville, Maryland, where HRSA is, but they're going to try and figure out a way, and I think with modern technology that shouldn't be too hard for them to talk together if they have a common project they're working on. There are also 10 regional HHS offices. How easy, after this I'll go to the internet and I'll show you the 10 regional offices. They should take an inventory of existing health and healthcare databases and share them, and recognize the need for and commit to develop a trained workforce that can create information systems to make them efficient end users. And again, that gets all together to the idea that I talked about, that when you're in a primary care setting, if you have the benefit of these databases, you can be reminded to either contribute to them or take from them as it suits your patient. Recommend 2, create common research and learning networks to foster support to integrate and improve population health with CDC and HRSA. They mention here the CMMI, Centers for Medicaid and Medicaid. Let me explain to you a little dynamic here. These recommendations disappoint me in some respects, and here's why. Back in the day, in the olden days now, I guess, when I was head of HRSA, they had a different structure for the Assistant Secretary for Health. All of us agency heads met together every other week. Head of NIH, head of FDA, head of CDC, head of HRSA, head of SAMHSA, Substance Abuse and Mental Health, and the Indian Health Service. We met together, shared our problem, just after, say, what are your problems this week? And I knew what NIH was worried about. I knew what the FDA was worried about. And it was really, really helpful. They don't do that anymore. They're siloed. They independently report to the secretary. And you can imagine somebody at the cabinet level is not going to have much time to worry about how HRSA might work better with CDC. But anyhow, if you meet together, it would be very helpful. So they said I couldn't make that recommendation to reestablish that committee that reported, or our biweekly agency head meeting, because it was above the scope of our project. We can't be recommending reorganizing government, but this is kind of a way of saying they should. And this is the most important thing, is CMMI. Every time we wrestle with an issue, it kept coming back to funding and how Medicaid needed to be at the table. And like I said, in the olden days when the agency heads met together, I met every quarter with the head of what was then called HCFA, Healthcare Financing Administration. I would say, I have this problem in our maternal and child health care block grant because of funding, or we don't have coverage for preventive services. So we would figure out how to do that together. And anyhow, so this is a structural change that I think really needs to be done, getting the agencies together. You can't look at the structure of the federal government and know it's too big. And I don't mean to make this a partisan discussion. I'm just saying that you really can't look at the granularity of these government programs without appreciating that they'd be better if they were distilled or less entities, more together. It's just grown enormously. Then we talked about the workforce needed to support integration. And you can imagine that we're very, very keen on bolstering the primary care and public health workforce because we think it's way out of balance, just like everyone agrees. And there's some good documentation of that in our report. Develop workforce needed to support integration. This is about Title VII, Title VIII. This is the Health Professions Training Assistance Act. And, oh, this was kind of neat. EIS, does anyone know what that is? Joe, tell us what an EIS officer is. These are I call these the white knights of public health. These are the guys that are deployed to go out and do disease surveillance and outbreaks or actually EIS officers are deployed throughout the United States and they're stationed generally in state health departments. We said maybe they should be able to work with community or federally qualified health centers. Maybe they ought to be able to work in primary care setting to help them do disease surveillance, or maybe share with them their skills on how do you measure population health, and then the community health center or the primary care setting could tailor their services to meet what's going on in their neighborhood. So that was a very constructive idea to get the EIS officers, those special epidemiologists, together with the primary care providers. Examination 4, improve integration of primary care and public health through existing HHS programs. We've already talked about the Medicaid Innovation Awards, translational awards from the NIH, clinical translation, National Committee of Vital Statistics, ARC, what have you. So anyhow, that previous slide, which was so busy, I think you appreciate from that there are many things going on in existing agencies that could help with this, but we won't know if they can until you get together. Okay, so Secretary should work with all agencies in the department. First step, develop a national strategy and investment plan for the creation of primary care and public health infrastructure strong enough and appropriately integrated to enable agencies to play their appropriate roles in furthering population health. It's a lot of words, but I honestly feel like their reception will be more taken seriously because of these financial incentives, imperatives to save money, and incentives to do it as well. The path to population health improvement will involve significant investment in the creation of linkages and across many sectors. This report set out to highlight opportunities for the first steps along this goal, most critical, blah, blah, blah. Anyhow, you can get the whole report yourself on the IOM. And like I said, the references are worth their weight in gold if you want to do research related to this.